Well, thank you and good morning. Thank you for that generous introduction. It's really a pleasure to participate in today's summit and congratulate Jerry and the rest of the team on organizing this. I'd also like to thank them for their gracious hospitality last evening. We had a wonderful dinner. As you get older in your career, one of the true pleasures is watching someone who you work with earlier in their career progress. And today really is an example of that. Just watching Dr. Estep's career blossom down here has really been one of the things that we're very proud of, myself and others 4 hours north of us here at UT Southwestern. So congratulations on everything you've done, and you certainly should be all thrilled to have this expertise among you. We're going to turn our attention now towards the epidemic of heart failure. And as you face your patient in the hospital or in the ICU, and you watch them, you recognize the severity of the situation they're in. And certainly it's a gratifying space for us to work in to know that we can make a huge difference in the lives of our patient. And really that's essentially why I do what I do, which is spend the vast majority of my time taking care of patients with heart failure. But what I'm charged with today is kind of taking a step back and look more from a global perspective and look at heart failure from an epidemiological perspective and look at what has been called an epidemic. I think as you'll look at some of these numbers, you'll agree that this truly is an epidemic. So these are the points that we're going to cover. We're going to talk about what I'll call the basics. These are just kind of some facts and figures to kind of allow you to get a handle on the magnitude of this problem that we're facing. I then want to talk about a special subgroup, specifically African Americans, because as you'll see, they suffer disproportionately from this epidemic of heart failure. And then I'm going to move towards the question about how can we get control of this epidemic? Are there ways that we perhaps can shift our care of patients and try to reduce the burden of heart failure throughout the country? So let's begin here. And heart failure is common, it's costly, and it's lethal. These are data from the CDC. This is looking at heart failure death rate per 100,000. The darker red is higher numbers. The darkest red, for example, is over 220 deaths per 100,000, whereas the lighter whites are under 50. And what is striking is that there's this huge gradient throughout this country, this variability, and one wonders why this exists. And then secondly, of course, here in Texas, we are in the hotspot for the epidemic of heart failure. We have massive numbers of patients who are dying, perhaps the highest in the country. So not only from the global perspective of the country, but for each of us in this room who work in Texas, this is a real problem we face on a daily basis. If you look at some of the numbers in the United States, it's anticipated that there are approximately 6 million patients who have heart failure. It's good for our job security. We'll always have people to take care of. Huge numbers of outpatient visits, 12 to 15, and then this real issue about the number of hospitalizations. About 1 million hospitalizations annually are due to heart failure. If you could advance that slide for me, please. Thank you. So this is looking at temporal trends from 1980 to 2010. This is stratified by gender, women in red, men in blue, and from 1980 to 2010, this is discharges in thousands. So in 1980, there were about 500,000. And you can see there's been a large increase. You'll notice at the tail end of this that there is a flattening of the curve. And so in the last 10 years or so, the number of discharges has been largely stable. But still, this is representing about 1 million hospitalizations annually in this country. And it turns out that when patients decompensate and are hospitalized, this is an important inflection point in their illness. If, for example, you look at patients who have chronic heart failure or decompensated heart failure and were hospitalized, these are data from the ESC heart failure pilot study, and they looked at patients either on the outpatient chronic or hospitalized patients and then just followed them for the next year. And what you can see is that the mortality rates are at least 2.5-fold. These are European data. And in the United States, most people would say that the one-year mortality rate following index hospitalization is about 30%. So somewhere between 2.5 and 4-fold higher one-year mortality rates if you take a patient who's been hospitalized for decompensation and compare them to someone who's stable in the outpatient setting. Now, it's not entirely clear if that's because the patient decompensated and got hospitalized and that meant that they were already deteriorating, or perhaps provocatively, maybe something that we're doing in the hospital to our patients maybe is contributing to this inflection point. I think it's unsettled yet. But certainly, once a patient transitions over from the chronic state to the decompensated state, their risk goes up dramatically. You could forward that again? Thank you. And so I think about it this way in terms of the risk of death over time. And here you are, kind of this chronic rate, probably class 2, 3, probably 7% mortality rate. And then once you get hospitalized, that rate incrementally increases. Now, another issue that we have to face is the concept of patients who get admitted and then get rehospitalized. And we all see this on a common basis, and we'll be hearing more in-depth discussion about this subsequently. Yeah, this is not advancing. If you could advance that for me, please. Thank you. And so the rehospitalization rate here, most people would say around 20% these days at 30 days and about 50% at 6 months. And as everyone has this concept about this revolving door where patients are coming in, we stabilize them, they go home only to decompensate, get readmitted, and what have you. Now, if you look at what's going on around the country in a temporal basis, these are interesting data that got published in the New England Journal last year. This is looking at 30-day readmission rates from 2007 all the way up to 2015. And what these authors have done is break down the reason for admission into a targeted condition by the Hospital Readmission Reduction Program. I think we're all familiar with that as part of the ACA, where our hospitals face financial penalties for high readmission rates. And so they looked at the readmission rates based on whether the patient had a targeted condition, including heart failure, MI, and pneumonia in the blue line, versus non-targeted conditions. And here, this dotted line here is where the ACA got passed in March of 2010. And what they noticed is that there's a striking decrease in the number of readmissions in the targeted conditions in the blue line compared to the non-targeted conditions, and then subsequently stabilized off, suggesting that as hospitals were being penalized for this, there's more attention being paid toward trying to reduce readmissions, leading to this reduction that they were able to demonstrate in this Medicare database. One of the ways perhaps that this was accomplished was through earlier follow-up. These are data from the Get With The Guidelines. These are temporal data from 2009 to 2012. And looking at this time of scheduled follow-up, blue line less than 7 days, red 8 to 14, more than 14. And what you'll see is that over time, there was a significant increase in the scheduled follow-up, reaching about 65%. Interestingly, when you look at the actual early follow-up, it's about half of what's scheduled, but still you can see that there's a significant increase in the early follow-up. So these data suggest that as hospitals were being penalized, the system started trying to reduce readmissions, and one of the easiest ways and most important ways to do that, we believe, is having earlier follow-up, leading to this reduction in readmissions for 30 days over and throughout the country. Now, not only are there financial implications of this, in terms of the prognosis, this is very powerful for our patients. These are data from Canada looking at subsequent outcomes of patients based on their first hospitalization, their second hospitalization in red, meaning 1 readmission. The black line is 2 readmissions. The green line is 3 readmissions or 4 hospitalizations. And what you can see in Canada, just like throughout the rest of the United States, about a 30% mortality after your first index hospitalization. But what you'll notice here is that there's an incrementally progressive increase in the mortality rates after patients are hospitalized. So each readmission is then associated with a higher mortality. By the time you get up to 3 readmissions, you're up to 60% mortality rate at 1 year. Most of us in the field are saying that if you have now 2 readmissions in 1 year, that gets you to a 1-year mortality rate of a little over 40%, probably identifies this patient as having advanced heart failure, which Dr. Eastet will be talking to us about later. So clearly, not only is it good in terms of reducing costs, but in terms of improving prognosis, if we can keep our patients out of the hospital from readmission, we believe that we'll be improving their outcome. So it is a common, costly, and lethal illness. Another basic concept is that clearly risk of heart failure increases with age. This is largely a disease of the elderly. If you look at the NHANES data, for example, these are characterizing patients between 20 to 39, 40 to 59, 60 to 79, or over the age of 80. If we first focus on the blue bars, these are the men, you can see that as people age, the risk of heart failure this is prevalence of heart failure, increases for men up to 10.6% over the age of 80. And if you focus in on the red bars, you'll notice a very similar trend. So as patients age, heart failure becomes more common. It's largely a disease of the elderly. These are important data from Don Lloyd-Jones now, almost 15 years ago, where he looked in the Framingham data set and tried to address the question, what is the lifetime risk of developing heart failure? Stratifying by both men or women. And what he found is that regardless of your starting age, the lifetime risk of heart failure for both men and women settles on about 20%. So whether you start at age 40, 50, 60, 70, or 80, your lifetime risk is going to be about 1 in 5 chance of developing heart failure. That's pretty striking. We look around the room, that's a lot of people with heart failure ultimately, even within this room, and that's true both for men and women. Another important epidemiological concept that I would consider a basic fact is this important ethnic differences with a disproportionate burden in African Americans. And I'll touch upon this later, but just to give you a glimpse of this, these are data now from the ARIC looking at first decompensated heart failure event rates, again stratified by gender. If we first focus on the blue and red bars, these are the men. Blue is white men, red is African American men. And what you can see is that African American men have higher rates of heart failure, decompensated heart failure event rates, incident event rates, especially at a young age. And you'll notice the same findings in the women, purple being the African American women, green being the white women, and you'll notice the incidence of decompensated heart failure is strikingly higher among people, especially when they're young, when you compare blacks to whites. So there seems to be something different about this ethnic group, and we'll focus on that subsequently. Another concept to think about is how we characterize patients with heart failure and the classification by ejection fraction. I think most in the room are familiar with the idea about HFrEF and HFpEF. And if you first start on that concept and you look at temporal trends, these are data now from the AHA Get With The Guideline Registry, and we'll be hearing a talk about this later as well. But again, for a glimpse of this, if you look at HFpEF, that's in the blue bars, and HFrEF is in the black bars, you can see that there's been a decrease in the prevalence of HFrEF over time. This is from 2005 to 2010, while there's been a significant increase in the prevalence of HFpEF. That's just the starting point, though. And I think many of us initially were thinking about it in terms of systolic and diastolic heart failure. We moved to this concept of HFrEF and HFpEF. The newer concepts are going to, I'll show you here. The first is this idea about the gray zone. Patients who have ejection fraction in between that 40 and 50%. And our European colleagues now are calling this heart failure with a mid-range ejection fraction, 40 to 49%. And this is in their most recent guidelines. It's unclear to me whether this is in fact a unique subset of the spectrum. That is, are these people really any different than the diastolics or the systolics? Are they in some way unique or not? Do they have different natural histories? This concept is fairly new and certainly something to keep your eye on. The other relatively newer concept is this idea about having heart failure with a recovered ejection fraction. So you have patients who develop HFrEF and then get treated perhaps with beta blockers, recover their ejection fraction, but still have heart failure. And so we're expanding our classification system between this 2-tier, HFpEF and HFrEF, and now we really have four tiers. We don't have as much data yet about the recovered EF group yet either, similar to the mid-range ejection fraction, but there are some data emerging. This was just published last year in JAMA Cardiology, looking at outcomes, cumulative mortality over 3 years, looking at HFrEF in the orange, HFpEF in the blue. HFrEF is worse outcome than HFpEF. But if you look at the heart failure with recovered ejection fraction, clearly a better outcome than those who have either HFrEF or HFpEF. So suggesting that this is a unique subset of patients as compared to the other patients that we routinely face. Something to keep your eye on, these two groups, to see as these data emerge over the subsequent years. Talked a lot about where we sit now. about the epidemiology of heart failure, kind of the current state. I want to move a little bit towards the future and take a kind of futuristic look and see where are we going in this country with heart failure. Well, there's some good news. These are data, at least in Rochester, Minnesota, there's some good news. This is looking at temporal trends in heart failure incident rates. This is from 2002 to 2010. The top line here is overall. The orange-yellow line here is HFrEF, and then the blue line is HFpEF. And what they were able to demonstrate in the study is that there is a decrease in the overall incidence of heart failure from 2002 to 2010, both on the left panel in women and in the right panel in men. And that's good news. Largely, this was being driven by a slight decrease in the incidence of heart failure with a reduced ejection fraction. And the authors postulated that this reduction in HFrEF was due to improvements in our treatment of coronary artery disease. And as we are getting better with patients with STEMIs and the like, that's then translating to better LV function and less risk of developing HFrEF. So that's the good news. But there is some bad news, in a way, and that is the aging of the population. And these are data from the US Census Bureau projecting what is going to happen to the demographics of the United States up to 2060. And it's pretty striking. If, for example, you just look at the ages 65 to 84 population, in 2014, 46 million, it's going to be over double that in 2060. And if you look at the ages greater than 85, you can see that there's almost 20% of the population is estimated to be over the age of 85 when it comes to 2060. Another way to look at that is how many patients will be 65 years and older, and that's here in this top bar, and you can see that a quarter of our population will be over the age of 65, or at least anticipated to be so in 2060. And we've already discussed how the rates of heart failure go up as patients age, and so you can almost predict where this is going to go in terms of what's going to happen with heart failure. And in fact, this is a policy statement from the AHA that did just exactly that. They tried to estimate the heart failure burden projecting up to 2030. And this was all based on expected changes in the population demographics, not any changes in the incident rates of heart failure. And this is what they found. This is projected heart failure prevalence by gender. This is from 2012 up to 2030. Male are in blue, female in red. And here you can see we're around 2.5%, and you can see it's dramatic increases over time. This represents an increase from about 6 million patients to about 8.5 million patients projected over in 2030. So clearly we are all going to have a lot of work to do if this is true. If you look now stratifying by ethnic groups, you can see that whether people are African American, white, or Hispanic, similar trends are expected, that there will be higher prevalence rates over time. You can already get this glimpse here. We talked a little bit about the incident rates. You could already see the prevalence rates among African Americans appear to be highest compared to other ethnic groups. Now, what's that going to do from the financial perspective? And that, too, is not good news. These are from the same AHA policy statement. They try to estimate costs, direct costs or indirect costs. This is in billions of dollars, and projecting huge increases in the costs, largely driven by this increase in due to the hospitalization rates that are going to happen as more and more patients develop heart failure. So this is clearly an epidemic that has public health implications, clearly as well financial implications. Okay, let me now turn our attention to the second point, which is looking at this ethnic group about heart failure in African Americans. We've already seen a higher incidence rate, that is decompensated heart failure, in the ARIC study, and we've seen the higher prevalence rates. But let's delve a little more deeply into that. And there's really 3 important epidemiological studies that have touched on this that I think are worth going over. The first is MESA. MESA is an NHLBI multi-center study looking at subclinical disease. The multi-ethnic study of atherosclerosis. They took 6,800 participants in 4 ethnicities: white, African American, Hispanic, and Chinese American. They had to be free of a history of cardiovascular disease at baseline, started at the age of 62, and then followed them for 4 years. These are the data in terms of incident heart failure by race and ethnicity. This is here now 5-year follow-up. And the top line is the African Americans, Hispanics, whites, lowest rates in the Chinese Americans. But again, you're seeing here the African Americans seem to be at a disproportionately increased risk. When they looked at why that might be, they looked at risk factors and they felt that hypertension and diabetes explain this increased risk, as well as differences among socioeconomic status, lower socioeconomic status being more common among African Americans, being associated with increased risk or heart failure. The second epidemiological study is from the Health Aging and Body Composition Study, Health ABC study. Here they took about 3,000 subjects without heart failure, almost evenly divided between African Americans and whites. A little older population, 74 years of age, followed these individuals for 7 years. And again, here are the data looking at 5 years follow-up. The black symbols are the African Americans, and you'll notice the top line here are the African American men. The next line is the African American women. Then you have the white men and the white women. And we can see again that the African Americans are significantly higher than the white counterparts, male to male, female to male, such that the African American women actually have higher rates than the white males. So pretty striking data about it. And in their study, very, very similar to what we saw in MESA, the burden of risk factors appear to explain this disproportionate burden. And in their observations, it was hypertension, elevated blood glucose, left ventricular hypertrophy, and smoking contributed to the excess of heart failure among the African Americans. And then lastly, I want to leave you with this epidemiological study, the Cardia study, which I'm going to call the remarkable Cardia study, because when you see the data, they're just so striking, it really gives you pause. This was a prospective epidemiological study of about 5,000 whites and blacks, and they started following these patients at a relatively young age, 18 to 30 years of age. So it's a much younger population than what we saw in MESA and what we saw in ARIC. And they followed them for an incident heart failure over the next 20 years. And this is what they found. This is looking at 20-year follow-up. The orange line is African American women, the blue is the African American men, and then the whites are down here. And you can see over 20 years of time, there's high rates of heart failure among developing in the African Americans and almost nothing in the whites. And the striking number here, I think, is when you look at the crude numbers, 27 subjects developed heart failure, and 26 of them were African American. It's pretty amazing, I think. We really put it in context for me about the disproportionate burden, especially among young patients, for developing heart failure among African Americans. Now, when they looked at the risk factors for the development of heart failure, hypertension stood out. These are looking at through the first 10 years. Remember, they were following heart failure through 20 years. And they just characterized patients as to whether they developed subsequent heart failure, those are the blue bars, or did not develop subsequent heart failure. And this is looking at the frequency of hypertension. And you can see this striking association that by the year 10, among the patients who developed subsequent heart failure, fully 70% had hypertension. So clearly, hypertension among the African American community it must sit right in the center of this risk for developing heart failure at a young age. Now, when they looked at total risk factors, hypertension was the strongest, but there were other risk factors: higher BMI, lower HDL, renal disease, depressed ejection fraction at 5 years on the echocardiogram. But it was not due to coronary disease, and it was not due to other lifestyle manifestations such as drug or alcohol use. We'll come back to these risk factors because I think these are going to have implications for a global society as well in terms of trying to reduce the burden. And then lastly, I want to show you these data from my colleague Dan Dries. He looked in the solved prevention data set. That, as you recall, is one of the landmark trials that showed the benefit of enalapril in preventing the progression from asymptomatic left ventricular dysfunction to the development of symptomatic heart failure. And he stratified patients based on their ethnicity and followed them. This is about 4 years of time. This is the African American placebo, African American ACE inhibitor, white placebo, white ACE inhibitor. And you can see strikingly higher rates if you compare placebo African American to white, ACE inhibitor African American to white ACE inhibitor, dramatically higher rates of progression in the African Americans, such that when you look at this, it's really striking that the African Americans who were treated with the ACE inhibitor still had higher rates of progression compared to the whites who were treated with placebo. So whatever the ethnic differences are, they're so powerful, they're swamping the benefit of the ACE inhibitor. So clearly, this is a subgroup that needs special attention. And so I'd summarize it and say African Americans have an increased incident heart failure at a younger age, we believe largely due to a burden of risk factors, and we've also seen this increased progression from some subclinical disease, ALVD, to clinical disease, symptomatic heart failure. Okay, let's move towards the last topic, and this is the issue about how can we get a handle on this? How can we control this epidemic? And one way to think about this is the curve I showed previously, looking at the projected rates of heart failure prevalence up to 2030. How can we bend this curve so that rather than developing this large increase, seeing this large increase in this prevalence, that we can somehow flatten it out, both for men and women? And I'm going to touch on 3 topics here, and clearly this is, there's no answer here, but these are my thoughts at least as you look at the emerging literature on this topic. The first is lifestyle parameters. The second is ways we treat hypertension and diabetes, and then a concept about should we be screening the population in some manner. So let's first talk about lifestyle. And these are looking at data from Sweden. On the left-hand panel are men, and on the right-hand panel are women. And they characterized the lifestyle based on 4 parameters of health: not a current smoker, physical activity greater than 150 minutes per week, a normal BMI, and then a moderate to a high adherence to a Mediterranean diet, fruits and vegetables, legumes, nuts, whole grains, fibers, and things like that. And then they looked at the number of factors. This is 1 factor, 2 factors, 3 factors, or having all 4 factors. This is the men, and looked at the relative risk of developing heart failure. And if the person in the population had all 4 of these healthy lifestyle parameters and was a man, this was the relative risk. That's a relative risk of 0.39, meaning a 60% reduction in the development of subsequent incident of heart failure if you had all 4 healthy lifestyle parameters. And here on the women, you'll notice that with all 4 factors, very similar, the point estimate here is 0.28, meaning a 70% reduction. So clearly, people who have healthy lifestyles seem to have a dramatically reduced risk of developing heart failure, at least in Sweden. If we look in the United States, we see very similar concept emerging. This is from the Framingham Offspring study, about 3,000 subjects. They came up with a point score, cardiovascular health, which had 7 parameters. And the point score went that if you had the ideal parameter, you got 2, intermediate was 1, and if you had the unhealthy parameter, you had 0. So the score went from 0 to 14. And it was based on blood pressure, BMI, diet, cholesterol, glucose, smoking, and physical activity. So as an example, if your fasting glucose was less than 100, you got 2 points. If you were intermediate, 100 to 125, you got 1 point. If you were greater than 125, you got 0. If you were a never smoker, you got 2. If you were a current smoker, you got 0. So you get the concept there. Healthier is higher. So, and then they followed them for 12 years. They had 188 incident cases. And very similar to what we saw in Sweden, as people have healthier lifestyles, this is hazard ratio, as that score increases, your risk of heart failure goes down. So one way one could hope to change this curve, flatten this curve, is by getting patients or getting people, the population, to adopt healthier lifestyles. Certainly not easy, but as these data are emerging, clearly there is an association with subsequent development of heart failure. Another aspect of this is physical activity and sedentary lifestyle. These are data that come from the California Men's Health Study, about 80,000 subjects, followed for 10 years, looked at incident heart failure by ICD-9 diagnosis, and then did a questionnaire. And we're going to focus on their estimates of physical activity. They categorized patients based on their METs per minute per week of moderate or vigorous exercise. So, for example, under 500 was considered low physical activity, medium or high. And then your sedentary time outside of work. That's time spent at TV, computer, reading, hours per day. Low 1 to 2, high greater than 5 hours per day. And then this is what they found. This is looking at the adjusted hazard ratios for incident heart failure. As your sedentary time will go along this axis first, as your sedentary time increases, there was an increased risk of heart failure. And here's your physical activity. This is from low to high. As you go from low to high, you can see that you decrease your risk of developing heart failure. So both increasing sedentary time increases the risk, and low physical activity increases the risk of heart failure, such that people who had both low physical activity and high sedentary time, that's this bar here, had an over twofold risk of developing heart failure compared to those people who had low sedentary time and a high physical activity. So certainly movement and exercise and fitness are going to be important if we're going to try and flatten this curve. Now, the question then is, how much physical activity do you need to do? And these are data from a cardiology fellow at my center, Ambrish Pandey, is a very talented fellow, and he looked at a meta-analysis of 370,000 participants. The guidelines in general recommend somewhere between 500, maybe 1,000 METs per minute. And essentially what he found is that that dose of exercise may not be enough. Higher exercise doses did lead to greater reduction of heart failure risk. You can see here the guideline recommended is 500 to 1,000, but at least in this meta-analysis, as you got more exercise, 1,500, 2,000 METs per minute, your hazard ratio went down. So perhaps we're not recommending enough exercise and we need to do more physical activity. Those data are very complementary to this study from Ben Levine, also at my center, where he did a really interesting study where he took healthy seniors who were over the age of 64, and then he categorized them by lifelong patterns of exercise. Sedentary was less than 2 sessions per week. Casual was 2 to 3 sessions per week. Committed, 4 to 5. Competitive, these were people who did 60 sessions per week and participated in U.S. Masters organizations. These were lifelong fitness enthusiasts. And then he performed a right heart catheterization where he manipulated filling pressures, so he can look at filling pressures, and then did echocardiograms so he can get an estimate of LV volume, and essentially created pressure volume curves to look at the diastolic function. And what he was able to show is that there's a graded risk in terms of diastolic function. For example, these are the competitive elderly subjects, and these, in this red line here, they have the most compliant left ventricle. So you can think about it for any given distension pressure. For example, if you go along this axis, how large a volume will you have? And so for this pressure, distension pressure, these subjects had the largest volume. They were the most compliant ventricle. And what he was able to show is that sedentary and casual exercisers, again 2 to 3 a week, were very similar. The committed exercisers, those are the people who had 4 to 5 sessions per week, were intermediate, and then this lifelong exercise were the most compliant ventricles, and in fact, in a different study, were superimposable to subjects who were 20 to 30 years of age, suggesting that lifelong fitness at a high level could prevent the aging of the ventricle, at least in terms of diastolic function. So putting these together, I think one of the emerging messages is perhaps we need to recommend even higher levels of exercise than what is currently recommended in most guidelines. Another issue is obesity. And clearly, in addition to the aging of the population, we're being faced with an obesity epidemic. These are classic data from the Framingham heart study looking at the association of obesity and the subsequent development of heart failure, red line being obese, overweight in green, normal in blue. And whether you were a woman or a man, you can see that as you were obese in the red, your risk of heart failure clearly goes up. And that's kind of where this was duplicated in a number of studies, and it's kind of where the field stood. It was unsettled, though, whether if you reverse the obesity, would you reduce the risk? Just because obesity is linked to development of heart failure does not mean that if you lose weight, that you're going to reduce the risk. And of course, I think many in the room are aware of the concerns about the obesity paradox in heart failure, where patients who are overweight seem to do better compared to lower weight once you develop heart failure. So this was an important question that really had not been well answered. But there's a couple of studies now that are just emerging. They're not yet published full length, but this was an AHA abstract from a few months ago. This was from Scandinavia. And what they did is they took subjects who were losing weight either through bariatric surgery, large numbers, 25,000, compared to 13,000 who were undergoing weight loss with an intensive lifestyle modification program. None of these subjects had heart failure at a baseline. You had to be a BMI over 30. And in general, the subjects who had bariatric surgery did lose a lot more weight than those who had the intensive lifestyle, almost 40 pounds. So this was a nice experiment in a way, because you're really looking at obese patients and now you're putting in this intervention of true weight loss. And what they were able to demonstrate, again, this is not yet published in full length, but at least in the abstract, there was a risk of heart failure at 4 years was reduced by 50% with this greater weight loss. So I think these are the best data that I've seen suggesting that perhaps we do need to be recommending targeting of obesity, specifically to be reducing the burden of heart failure. Okay, let's move towards another potential way to bend the curve, and that is with the treatment of hypertension and diabetes. And that's really, hypertension has already been discussed at length because that really is a central parameter in terms of the development of heart failure. These are data from Framingham, looking at the hazard ratios associated with various risk factors, hypertension, MI, angina, valvular heart disease, LVH, and diabetes, and then the prevalence. Combining those, they were able to come up with a population attributable risk. Yellow is men, this blue line is women, and you can see that hypertension wins. It is the dominant risk factor from a population attributable risk perspective for the risk of heart failure. So certainly, if we can improve the way we treat hypertension, we have a real chance at altering the development of heart failure. And I think the SPRINT trial needs to be discussed here in terms of, as I think everyone in the room knows, the SPRINT trial was sponsored by NIH, targeting a blood pressure less than 120 as compared to targeting a blood pressure less than 140. And the less than 120 arm won overall in the composite endpoint, but I'll just highlight the heart failure, the risk of developing heart failure. This is from the New England Journal publication. And the point estimate here was about 0.6, meaning there was about a 40% reduction in the risk of heart failure when you targeted a lower blood pressure. So if we want to get a handle on this from a population perspective, and these data are true and replicable, clearly targeting a lower blood pressure offers us a chance, at least, of bending the curve. The other exciting data, I think, come out of the diabetic space, and this is with the SGLT2 inhibitors here, published from the Empagliflozin outcome data, looking at placebo versus Empagliflozin, and showing that the hazard ratio was dramatically reduced for hospitalization for heart failure. So it is possible, as these data are replicated, if this class of drugs, this SGLT2 inhibitor, does in fact reduce the risk of heart failure among subjects with diabetes. This too, I think, from a population perspective, given the magnitude of diabetes, offers us a hope for bending the curve. And then lastly, perhaps the most provocative concept, I would say, is should we in some way be screening the population and treating those? And here we have an important trial called the STOP-HF trial. This was a trial that took 1,300 participants, all of whom had at least one cardiovascular risk factor. This was conducted in Ireland between 2005 and 2009. And this was a strategy trial. They measured BNPs, and if the BNP was over 50, that would then lead to an echocardiogram and what they called collaborative care with a cardiologist in addition to the primary care physician. So they screened the population. If you had a BNP over 50, then you went and got an echo, and then you essentially had involvement of a cardiologist in the care of that patient. The primary endpoint was a composite of new heart failure or left ventricular dysfunction. That could either be systolic or diastolic. Mean follow-up was 4 years, and it was a positive trial. The composite of, of heart failure or left ventricular dysfunction, again, systolic or diastolic, was significantly reduced with this intervention. They looked at the development of asymptomatic left ventricular dysfunction. This is, again, both systolic and diastolic. And again, we're able to demonstrate a significant reduction, almost 50% reduction in the echocardiographic parameters of left ventricular dysfunction. There was a trend, it was not significant in the development of heart failure, from 2% down to 1%. But one would have to believe that if these data are true and you're reducing left ventricular dysfunction, if you followed patients longer, almost certainly you would anticipate that you would impact the burden, the development incidence of heart failure. So these data clearly need to be replicated in other populations, but at least are provocative enough to get you to be thinking that this, in fact, is perhaps a reasonable strategy to consider screening the population with natriuretic peptide levels and then targeting those who are elevated with an intervention by echocardiographic and perhaps involvement cardiologists. The main intervention that was done was uptitration of RAS inhibitors, as one might anticipate, and that could be the pathway through which you prevent the development of symptomatic heart failure down the road. So let me summarize what we talked about. From a global perspective, we deal with this on a day-to-day basis. It's an amazing field to be in. But when you step back and you look at this epidemic of heart failure, it really is somewhat mind-boggling. It's common, costly, and lethal, and as our population ages, it is going to just explode in terms of the number of patients we're going to be facing. When our patients decompensate, that is an inflection point. Automatically changes that patient from chronic heart failure, 7% mortality rates, up to somewhere between 20 and 30% over the next year. And this expansion of categories of ejection fraction is really interesting. We just got used to HFrEF and HFpEF, and now we got to start talking about mid-range EFs and recovered EFs as well. And it'll be fun to watch as data emerge about these new subphenotypes, about the differences and how we should target those. And I do think one cannot help but be interested in this important subgroup of African Americans and how can we improve our treatment of that important subgroup. And then strategies to bend the curve. I don't have answers, but these are my thoughts as I've looked at this lifestyle modification, fitness, obesity, diet. If we can somehow impact the population, we can certainly have a chance of reducing heart failure. And I am very excited about the new agents for diabetes and perhaps our lower targets about how we treat patients with hypertension. And then as I finished on this provocative concept about using natriuretic peptides to screen the general population, or at least those who have risk factors, and altering care is pretty exciting and really be a paradigm shift if this could be duplicated. Thank you so much.